Construction is an industry built on pride, resilience, and getting the job done, often under intense pressure, long hours, and physically demanding conditions. But behind all of this, many workers are quietly struggling with substance use, mental health challenges, and the stigma that keeps them from asking for help. The impact isn't just personal. It affects safety on job sites, productivity, and the well-being of entire communities. In this episode of OCS Talks, we're talking to Michael Varieur from the Novo Treatment Center. Michael brings deep frontline experience supporting individuals and families navigating addiction and recovery, and works closely with employers and unions to build practical, compassionate pathways to help. Today's conversation is about awareness, prevention, and most importantly, hope. Whether you're a worker, an employer, a union leader, or a family member who cares about this industry and the people within it, this is a discussion that matters.
Welcome to OCS Talks, your source for all things related to Ontario's unionized ICI construction sector.
I'm Brian Barron, CEO of the Ontario Construction Secretariat. Michael, welcome to the podcast.
Thank you, Brian, and thank you for the invitation to speak about the Novo Treatment Center, as well as explore concepts related to addictions and residential treatment.
Before we get into kind of the industry and why addiction is an issue, can you tell us a little bit about the Novo Treatment Center and its mandate?
Yeah, absolutely. And, as we describe talk about De Novo here, it really is built by industry for industry. That's where we came from. De Novo is a drug and alcohol treatment service. It operates as a partnership between the management and the unionized members of Ontario's construction and building trades. So we serve unionized workers, employees, employers, management, and their families. And when you think about, the term de novo, it actually means a new beginning. So, we really, value that heritage. We were incorporated back in 1991 when a group of members from Ontario's building trades came together, identified that there was a problem, with alcohol and drug use within their sector, and they wanted to help. So they came together and formed, what we know as De Novo Treatment Center to serve those unionized trades. And at that time, it's contributions come through membership and through the employers, and funded a trust called De Novo Trust. And during that time, they would engage, De Novo Trust would engage in system navigation. So if there was a referral for, say, alcohol addiction, De Novo would actually help the person get connected with another external provider. And at that time, that provider was called Renaissance. And we're still very closely aligned with Renaissance Treatment Center in Toronto. And so that kind of system navigation service continued until about 2002, when the trust purchased its first property, its first treatment center in Sundridge, Ontario. It had 21 beds at the time. In 2019, it expanded into Huntsville, where we currently reside right now, and we have up to 43 beds here. So we offer a 35-day residential treatment program. We're based on the 12-step model of abstinence, Minnesota model. And for those people who complete our 35 days, they are enrolled in voluntarily into an aftercare program, which continues for up to a year. We also offer family programming, and we support the youth of the members and the employees and the employers through a partnership agreement with another organization. So our younger people who are under 18 will help them get connected with a very specialized service to meet their individualized needs.
I think the unionized environment in construction, I think, has a lot to be proud of. I talk a lot about sort of investment in training, safety, that sort of stuff. But this is certainly one of those areas where, that it kind of, I think there's a fair bit of pride that goes behind this, because it's one of these things that truly sort of takes, a real issue, a real tangible issue that's facing construction and is trying to solve those issues. So I think it's something that, for me anyway, I think this is a real success story. Over the past sort of 5 to 10 years, I've heard discussions around addiction becoming probably a little more accepted kind of in general. I'm sure they're still very difficult. But one of the things that I do want to ask you, because I'm not entirely sure if people really understand why addictions occur in the first place. So I'm wondering if you can provide a bit of insight as to how an addiction like the ones you help to treat start.
How does an addiction or alcohol, drug addiction start? That's a really complicated question. And
I'll apologize for that, but I think it's
yeah,
important.
lots of differing opinions and beliefs around that. We can talk a little bit about, job specific risk factors in a minute, but I think as a starting point, just as a conversation around addictions, again, there's lots of reasons why people would get introduced to alcohol and drugs. Social, family, pain management, many different reasons around how people get introduced to a drug or a drink. But what we also know to be true is that over time, our bodies physically become dependent on whatever we're using. Our bodies become tolerant to whatever we're using. And so people who frequently use alcohol or drugs can expect to have an increased frequency or a desired amount. So they'll either use more or more frequently as our bodies become dependent, as they become tolerant, in order to get the same effect and outcome. Maybe a couple beers used to you get a little buzz with a couple beers, and now a couple beers doesn't even touch you anymore, right? So that increase in use over time happens as drug and alcohol use increases. We know that it impairs our functioning. So we have cognitive functioning, physical, emotional, decision making. So drugs and alcohol will affect that. And as our use increases, we have those side effects associated with what we're using on a day-to-day basis. And those side effects over time will start to impair our lives, worsen our day-to-day experiences. So we're using more and more frequently. We're thinking about using more so that it's this persistent desire where it's always in the back of your mind. It's always there. We spend much more time focusing our efforts around getting a drug or a drink and then consuming it. We have our cravings. And then we start, having failures in our day-to-day functioning. So our job starts to suffer, our relationships start to suffer. We stop engaging in those things that we normally do, recreation, social activities. And then we might actually start engaging in some hazardous situations. So, the person who drinks might be charged with impaired driving. So now we have some other kinds of consequences, not only for ourselves, but we actually might create harm for somebody else. We then have, psychological and physical health issues that might occur. So you have secondary health issues and psychological issues and mental health issues that start to occur as a result of your drinking and your drugging. And then, again, we talked about tolerance. And then when we try to stop using, we now are faced with these really overwhelming symptoms of withdrawal, which really does make it difficult for people. So ultimately, the addiction becomes really all encompassing. To a degree, there's a phrase often said where addiction is giving up everything for the one thing, which is your drink or your drug.
Yeah, it's kind of interesting. So, through my years at the government, and most recently when the new naloxone legislation came in and that sort of stuff, it became very apparent what a lot of the issues were, and they started in a lot of cases as relatively sort of minor injuries, things that were treatable, but due to the nature of employment and construction and that sort of stuff, people will usually push through that kind of thing, creating sort of bigger injury, requiring more painkiller, requiring that sort of boost or that sort of thing from a drug. So it's definitely one of those things that I think is becoming far more well known, and unfortunately it's bringing to light sort of a much bigger issue. So I guess my next question, I think you touched on it sort of briefly when you talked about sort of pain, you talked about sort of the difficulty of the job and that sort of stuff, but why do you think, can you sort of expand a little bit on why you think the construction industry is particularly vulnerable to alcohol and substance abuse?
Yeah, thanks, Brian. Great question. De Novo's actually has some pretty good research and data on this. So we've been engaging in research back to 2021 through some funding that we've received through Skills Development Fund. And one of the outcomes of that research has been to identify what we call the 5 primary drivers of addictions within Ontario's construction and skilled trade sector. And this has come through our research with over 16,000 participants, and we've engaged in various focus groups and surveys. And this has been done in partnership with other organizations such as the Building and Construction Trades Council of Ontario. So, one of the top 5 drivers within construction trades is the work habits and the schedule. So, the participants in this research really identified this to be the number one primary driver. So, you've got physical pain because of the work that we do, hard labor, people get injured, as you mentioned, Brian, and through that injury, you have pain management, and maybe they're prescribed an opioid. They become tolerant and dependent on that opioid, and now we have a progression of an opioid addiction as an example. So you have, the work habits and just the whole intensity of the work, long hours. Is another risk factor. So people are tired, they're overworked, they not enough sleep, and the expectation is to perform. So it wouldn't be uncommon for someone to be taking stimulants to keep themselves alert and keep themselves on task. And they're high performers, and it's great to have a high performer on the job site. But the question that we would start asking is, how is this person able to maintain these long hours and this high performance, and without some sort of assistance in that way? So other things, not eating, poor, the health and the lifestyle that goes along with that, working shifts, decreased in sleep. So, the work habits in the schedule is a primary driver. So you're working hard, you get home, maybe you need a drink to go to bed. Also, the personal relationships was another real primary driver. So, your people would probably know it better than I, but working away from home, you're on a job site, you might be away for days or weeks at a time. It's really difficult to maintain those close personal relationships. And when we're away from our people, we're feeling isolated, we're feeling cut off. It's really hard to have sustainable, healthy relationships. Who are we talking to? Who are we sharing? Where are those connections? Do I get to see my kids at night? And I'm spending most of my time alone. So, and maybe I'm spending most of my time with my coworkers, and we're working these long shifts, and we're all tired. So we come back to the hotel and have a couple drinks and then go back to bed and just rinse and repeat and rinse and repeat. So that personal relationship that's connected with the job itself can really lead to and promote, stress, anxiety, depression, another primary driver, the mental health conditions that are really connected with that. So again, coming back with the work-related stress, those feelings of being alone, disconnected from your loved ones, can really start to promote or foster senses of, sadness, depression, hopelessness, anxiety, might be, and workplace stress. Maybe there's your job, you're on a timeline, or you have to have a certain quality standard. So there's a lot of job-related stresses around that too. Finances, interestingly enough, was considered a primary driver. People might be making really great wages. However, often what we hear is that people are always working themselves out of a job. So never really know what the next job's going to look like. And that financial insecurity for themselves and also for their family can be a significant stressor for them. How do we pay my mortgage when the job's going to be ending at a certain date and time, right? And where am I going and what am I doing after that? Also, what we've understood is that people can get themselves in a little bit of a cycle. So it's also a feast and famine. And when they're making money, they have lots of money. And when you have lots of money, you're going to spend your money. And we spend our money on our extracurricular activities, which may include drinking or drugging. So we're spending money when we have it. And then when we're out of a job or we're waiting for the next job, we don't have those funds to support our lifestyles. But by that time, now we're accustomed to or dependent on a specific lifestyle, like drinking and drugging. So that would really definitely create some tension within your relationships and your partners and your spouses for sure. And then lastly, discrimination and abuse on the work site. So bullying from your coworkers or maybe even your supervisors, physical abuse, verbal abuse, mental abuse on the job site's not uncommon. And that's not an uncommon story that we hear from the people here at residential treatment. Also, racialized or ethnic discrimination and gender and sexual orientation within the job site. And then also, if you happen to be of another gender, another sexual orientation within a very male-dominated industry, that could be very, very challenging also. So we do have a lot of people arriving here with trauma backgrounds and really rooted in that discrimination and abuse. So all of these 5 drivers that we've talked about, they're all very interconnected. There's a lot of connective tissue between them all. And that results in a very unique, individualized experience around someone's driver of their addiction, whether it's alcohol, drugs, or anything else for that matter, and their mental health conditions.
So that's interesting with the 5 drivers. I mean, that's one of those things where each one of those, and having come from construction myself, I know I've sort of experienced a fair number of those. I mean, there are a number of different stressors in the construction industry that you don't really see in, other contexts, right? Like in other industries and that kind of thing. It's one of these things where, you're able to go home every night. You're going back to the same place. There's some level of stability, all those different pieces. So I can certainly see where some of those would be major stressors that lead towards some level of addiction. Now, one of the things so in preparation for this podcast, you had actually sent me some pretty alarming statistics. And I was actually kind of blown away because I understand that you guys have 43 beds at Novo and that kind of stuff. But the numbers that you sent me, so between January 1st of 2025 and December 1st of 2025, so an 11-month period, unless I've got that wrong, you had 682 individual referrals, which was an increase of 13% compared to 2024. And there was a number of other numbers, but let's unpack a couple of these first. So the 682 individual referrals, like I'm blown away by that. That's a lot of people. So why do you think there's that many, and why do you think there's been an increase of 13% from last year?
I'll reply to that question by just commenting that I find it interesting, not necessarily yourself, Brian, but just socially that society continues to struggle to comprehend the prevalence of addiction and mental health in society. And these numbers just reflect the prevalence that occurs. So, if we think about chronic disease or chronic illness amongst Canadian adults, the Public Health Agency of Canada back in 2019, published some statistics. So we think of dementia, 7%, cancers, 8%, COPD's 10, asthma is 11, diabetes is 11, osteoarthritis is 14, hypertension, 25% amongst adults in Canada. Canadian Center for Addiction and Mental Health, they have their stats for mental illness. And so they're suggesting that by the age of 40, 1 in every 2 Canadians will have or experience a mental illness. So that's 50%. And so here's hypertension at 25%, and we have 50% for mental illness. When we think about the Canadian Health Survey that looked at different types of employment within Canada nationally. So this is 2023 statistics. Between 20 to 25% of people employed in the construction and trade sector nationally have a high risk relationship with alcohol. So again, when we think about, wow, that sounds like a lot of people, or that the rate or the prevalence seems high, that's because it is high. And it is.
So I guess, do you think then that we just don't like talking about mental health and addiction? Is that probably the bigger issue here that we're dealing with? Because if you're doubling that number from like hypertension and that kind of stuff in terms of the issue around mental health, is it just that
these are not new statistics, although they're new current data. This isn't new for the people who've been in mental health and addiction industry for a lifetime. We've been talking about the prevalence of mental illness at this rate for decades now. So Brian, I think you're approaching maybe some of the area of concern here is, the stigmatization of mental illness and specifically addiction also within our society. Difficult topic to talk about. We're often, you're in a conversation with people and people are comfortable talking about their diabetes or their loved one who's, survived cancer. But it's more difficult or a more uncomfortable conversation to talk about their loved one who's living with the disease of addiction and had to, has been through residential treatment 3 times. Those are very different comfort levels we tend to find socially in our environment. Why is that? Stigma is a primary driver of that.
That's unfortunate because you think about somebody who needs help and that being a barrier for them and not wanting to sort of bring that up is pretty significant in terms of really kind of what their outcome is going to be, I would think.
Absolutely. And stigma is one of the, fundamental reasons why people don't ask for help, because they're afraid to ask for help, because they're afraid of what people will think of them, and they're afraid of the consequences. Am I going to lose my job if I, go to my supervisor or my boss or my union and say I have this issue, struggling with cocaine on the, and what's going to happen to me? What are they going to think about me? Are they going to trust me? Lots of stigma. It is one of the primary drivers for people not to ask for help.
It's interesting to me because one of the big topics right now, and I think it's becoming more common, is drug and alcohol testing on job sites and that sort of stuff. And they're using it in a lot of cases in, trying to assess, who, not necessarily who was at fault at an accident, but contributing factors and that kind of stuff. And there's been a lot of discussion around what sort of employers can do, what unions should be doing, and that kind of stuff. And I think, the more that we talk about these things, the more we bring them to the forefront, the more that we kind of take that seriously and try to proactively deal with these issues versus sort of accepting it as probably some level of our reality kind of thing. Brings me a bit of hope anyway, that at least we're moving sort of in the right direction. We're starting to take some proactive approaches to this issue.
Absolutely, Brian. And I think that's, one of the strengths of this industry, the construction and trades, is, over the past several years, it's, the industry itself has really dug into having those uncomfortable conversations about addictions, mental health. There's a lot more people talking about it. We're having a podcast on it. I've been to the convention in Windsor the last couple of years, and, we're doing presentations on this, and people are genuinely interested and wanting to have a conversation about it. Everybody will know somebody who's living with an addiction or a mental illness.
So I want to go back to the numbers quickly. So I started with the 682 individual referrals, and you've got 417 scheduled admissions and 313 individuals at the aftercare program. So let's walk through, what is an individual referral? I want to understand that a little bit better.
Sure. So a referral is a person who's either picked up the phone or however, they've called Novo and they said, I'd like to self-refer. I need to come into treatment. I'd like to be able to come to treatment. Or it's a referral through their union or their employer. So, coming back to Novo, we're funded as a health and benefit plan for those contributing employers and union payers. And so the union can actually call on behalf of the client as well. So either the person self-referred or their union or employer called in their behalf. So that's 682 times a person has called us this year already.
Okay. So now with the scheduled admissions, so presumably not all 682 actually enter into the program. Do I have that correct?
That's correct. So there's a process that anyone would have to go through for an admission to a residential treatment center. For us, we have an intake assessment, and there's a whole series of assessment level processes that occur, around medications and health conditions and so forth. So lots of questions and answers, some homework assignments for the people who are asking to come to treatment. And sometimes that just never gets completed, or they stop halfway through the process. We might not even hear from them again. So the idea of a scheduled admission is somebody's actually completed the referral process, and then we've given them a date and a time.
So it is not an automatic. If I was to make contact with you, it is not an automatic that I'm getting into the program. I have to be able to demonstrate that I can meet sort of the criteria that's required to get in.
Yeah, and the criteria is fairly low. There's not a lot of barriers here. The first requirement is that you have to be a member in good standing with your union, or an employer, an employee of an employer group. So, we have to confirm that the person's eligible through those health and benefit plan, because it's a no cost to them when they come to de novo, right? Because they've already paid on behalf of the trust.
Yeah.
So that's the first process. After that, we do a screening or an intake assessment to get to know the person. We have to understand what their level of use is, what are they using, risk factors, and their whole psychosocial history helps us. And so we complete that process. There's a process around medications. So this is a drug and alcohol treatment center. We need to know what the person is prescribed for medication, why they're taking it, how much they're taking it, when they're taking it. So the whole medication reconciliation process needs to occur before they arrive. Some treatment centers require complete abstinence from all medications unless it's but we will work with people with opioid replacement therapies and so forth. So we work with the physicians and the client and the pharmacy to best understand what medication the person is receiving or needs to receive when they're here. That can take some time because they have to do some homework, right? And oftentimes the delay will be around them being involved in getting their medications in order. Then we require 3 days of abstinence. So they have to be clean for 3 days. Because there's risk factors. If they show up and they've been using heavy, they might go into withdrawal while they're here. And we're not a medical facility, meaning we don't have hospital level care here to respond to that. So we have this abstinence process, and we'll help the person if they need to get connected with detox. But they will still be provided a day, like an admission date before that abstinence. So really it's just around completing the referral, completing the intake assessment, getting their medications in order. Once all of that's completed, we then give them an admission date.
And so when I take a look at those scheduled admissions, you've got 417, just doing some quick and very basic math. I haven't actually run through it, but you've got 43 beds. The program runs for, I think you said 35 days. So you're running pretty much full all of the time.
We try to the best of our ability. When we're full from our waitlist perspective, 35 days, it's is residential treatment. So you can expect 35 days out is probably your next admission date, unless of course there's, someone cancels or doesn't show. It's difficult for us on a day-to-day basis, managing admissions. For example, yesterday we had 4 admissions, 1 person showed up. So, they were given an admission date and 3 people just didn't show. So we then go into, we're phoning them and calling them, trying to connect with them. Maybe they need some help getting here. We don't know. So we try to help them arrive here. And at some point, we can't admit anybody unless we start moving people forward. Right. So there's another person waiting for that bed 35 days out. So unless that person wants to move up, it really does make it difficult on a day-to-day basis to manage those beds. Yeah.
Yeah. Given those challenges, I would say that's still a pretty impressive number. 417 scheduled admissions, and you're getting people in. Unfortunately, I mean, I'm sure you would much rather not have people there where the issue isn't there, but that's not the reality kind of thing. Like it's
no, we're healthcare, and the need is there, and that's what we're here for. So we'd rather have the referrals and the people scheduled for admission.
Now, what about this? So you've got 313 individuals in aftercare, in the aftercare program. Can you walk us through that?
Yeah, so aftercare is a program that we offer people who graduate. So about 80% of people who arrive at the treatment center will actually complete the program, which is 35 full days. Those people who complete 35 days and they graduate will be offered to participate in aftercare. And aftercare provides ongoing weekly meetings, supportive phone consultation with counselors for up to a year. So it's really that ongoing support to help them with the relapse prevention and maintaining abstinence.
I have to imagine that's probably one of the most critical parts is once you're back out, you're out of the facility and that sort of stuff, that follow-up piece, holding people accountable, trying to make sure that they're sticking to the program has probably got to be one of the most important steps, I would think.
It is the most important step. The 35 days of residential treatment is not a one and done situation here. It's just really the starting point of somebody's ongoing recovery. And they build, a relapse prevention plan while they're here. They're preparing for returning home with their loved ones. They're preparing to return home with with their employers. And so then they're going to need ongoing support with that. They're really, we endorse them getting connected with a home group, whether it's AA, CA, or NA, whatever their needs are around there, and they get a sponsor. So then they participate in a 12-step fellowship when they return home, and then connect with one of our counselors on an ongoing basis through this aftercare program to touch base with their counseling needs and the relapse prevention needs for sure.
Part of this, I mean, a portion of this podcast is bringing awareness to the issue and that sort of stuff. But I'm also aware that you may have some people who are listening who, they're either thinking about, the issue for themselves or somebody that's close to them and that sort of stuff. I'm wondering if you can give us sort of a bit of a sense as to, once somebody is admitted to the program, what should they expect? Right? Like I have to imagine that making this decision could be somewhat overwhelming for people. So what are they looking at when they're admitted?
Residential addiction treatment is not a vacation. So from time to time, we have people who arrive here with this idea that, they're just going to get 35 days of clean and sober time. We actually have some people, we're often called the cottage within the trades. So it's up in Muskoka. It's a nice setting, trees and birds, etc., like that. And so some people think, I'm just going to take my 35 days and have a vacation, essentially, up in Muskoka at Novo Treatment Center. But residential treatment is not a vacation. It's challenging. It's a lot of hard work. It can be quite stressful for people. They can expect to be very, very busy. So we offer 66 psychoeducational groups over 35 days, 8 to 10 individual counseling sessions. There's homework, there's readings, there's reflections, there's 12-step meetings every day. We have optional programming every day. Additionally, over and above that, there's individual responsibilities. So we have people mopping, they have to keep the building clean. So this is their own home when they're here, and they have accountabilities around that too, and garbage and cleaning the dining hall and cleaning the floors. And so everybody rotates through all of that. They're living with up to 42 other people. And in the reality sense, we didn't get, you don't get to choose who you're living with or even who your roommate is. So you're living with people in a congregate living setting. You're sharing bedrooms, washrooms, showers, dining hall. You have different personalities, different backgrounds, different behaviors. So that can be quite stressful and overwhelming for some people as they're trying to adjust for that, especially if they're, single and they've never had to really, share that kind of space. What else can I share? Within a residential treatment center, we have various boundaries that we also uphold, not only for just the maintenance of a healthy and safe environment, but also from a recovery-oriented perspective. So no cell phones, no internet, no computers. So disconnected from technology for 35 days. Access to phone time. So there's a window of a week after you arrive where you don't have access to a phone, because we're encouraging you to be focused on yourself and why you're here. Oftentimes, reaching out and connecting with our loved ones or our friends out in the community can be a distraction for us, right? So we're encouraging people to really focus on ourselves. And then week 2 through 5, every day they have a phone period, but they're assigned their own, they get to pick and choose their own time, but it's a limited time again. So, that's a different kind of experience for a lot of people, is that disconnection from technology and phones and communication. We really promote civility and treating everyone with respect within the environment. So again, coming back to some of these other kinds of work-life behaviors, of social behaviors where people engage in bullying and harassment, or even joking that might come, people might feel it's, I'm just joking with you, but actually it's mean-spirited, can really hurt someone. So we hold people accountable to civility and respect within the community. And the expectation that not all of my requests will be fulfilled is also another reality for people. So one of the common experiences of addiction is I want what I want when I want it, which is very much challenged here within De Novo Treatment Center.
I mean, I'm blown away by the number of programs you have. it's kind of interesting to think when you sort of divide out that time over the 35 days, it doesn't like there doesn't seem to be a whole lot of time for, I'm trying to think of a way to do that, say this where it's not, because I don't mean this in a negative way, but you're not allowed to stray a whole lot during that time. It's like the goal is to work when you are there. Like it seems very goal oriented.
It is a treatment center. It's a treatment program. We're here as a tool for people to engage in their own recovery. So we're here to give them information. We're here to help them engage in their own self-reflection and to learn about themselves and to start practicing new behaviors. And so this really is a very busy time, and people get what they take from the program.
I think that's excellent. Now, in terms of the people running these programs, can you walk us through sort of what that looks like? Like I'm sure there's lots of people with all sorts of different qualifications and that kind of thing, but who are they going to run into? Where are they likely to run into who are actually facilitating these programs?
Yeah, our treatment program is delivered through trained addiction counselors. And those addiction counselors come with various, backgrounds, psychology, formal addiction training. We have nursing on staff. I'm a registered nurse myself with mental health and addiction training in the background. But everyone, like all of the counselors, have they're trained in this area.
Now I'm curious. So I think you touched on it a little bit, and it's sort of almost like a bit of a two-part question I've got for you, because, I imagine this program is voluntary. If somebody wants to leave, there's probably no fence around this. And then in the same vein, I mean, in terms of kind of restrictions and that sort of stuff, this isn't a situation where they can just kind of walk down the road to a bar if they feel like it, kind of thing. I assume there's some pretty strict rules around what that looks like.
Definitely. So, first of all, you're correct. It's 100% voluntary. Everyone has the right to choose. No one's forcing anyone to be here, or De Novo is not forcing anyone to be here. From time to time, people may perceive or believe that they're being forced to be here, or that De Novo's forcing them to be here. But those kinds of experiences really relate to what drove them here in the first place. So some people are here because they've identified they are living with an addiction. The addiction's become overwhelming and all-encompassing, and they need to do something about that. Other times, people arrive here because they have some legal or justice-related issue or some offense. Maybe somebody's been charged with drinking or driving or domestic violence, and there's some sort of legal or justice driver there, which is directing them to addiction treatment. Sometimes there's some psychosocial issues. Maybe they might have a partner who's, this is your last chance. You either get help or I'm leaving you. So everyone's arriving with their own reasons for being here. And sometimes those reasons may feel like they're being forced to be here. However, it's 100% voluntary. So that person can leave whenever they choose to leave, and we won't stop them, although we'll probably have a conversation about it, right? And try to help them to make an informed choice. But around restrictions, yes. So we have some expectations. All residents have some responsibilities. They have various rights. There's benefits and risks for participating in residential addiction. We review those with them. They have their rights within the treatment center, and then they have what we call responsibilities as well. We have some hard stops where if people start engaging in these types of behaviors, we will ask them to leave. And those include sexual or physical or psychological violence, including weapons offenses. Of course, that's not tolerated. The possession, use, and distribution or concealment of drugs and alcohol, again, a hard stop. If there's destruction or vandalism of the property, or if we have to call the police in relationship to behaviors, they'll be asked to leave. Gambling of any sorts, again, is not a condoned behavior. Pornography, sexual activity, sexual relationships, again, not condoned here. And yes, Brian, you're correct. The absence of leaving the property without our approval or without being chaperoned would also be a reason for an administrative discharge. So, yeah, we're in a community. If someone decides to leave and go to the bar and have a drink, they'll be asked to leave.
Yeah. Well, and I assume, when we take a look at the voluntary nature of all of this and everything else, I would think that success is directly related to the willingness of the person to really kind of commit to addressing that problem. So can we talk for a little bit about kind of what the success rate looks like? What does success look like for a lot of these people? So yeah, if you can expand a bit on that.
Statistically, it's hard to, like, we don't have a lot of good data right now statistically, and then that's part of our strategic plan is to develop a much more fulsome and accurate framework of evaluating the effectiveness of our service longitudinally over time for people. But what we do know to be true is if somebody graduates, they've at least been clean or sober for 38 days. That's their 35 days plus 3 days in advance. So that's a huge success for a lot of people. That might be the first time in their life. Of the people who've started the program, 80% will have completed. And then of the people who complete the program, we have, based on our research, we have about, plus or minus 80% of people will remain abstinent or mostly abstinent 6 weeks after graduation. And then of those, about 60% 3 months after graduation. And then beyond that, we don't really have a lot of good data on that.
It's got to be hard to keep track of that too, right? Like it's trying to respect people's privacy, that sort of stuff as well, which I imagine causes some issue with trying to collect that as well.
Yeah, that's all really through our aftercare program. And right now within our strategic plan, we're working to modernize that aftercare program so we can provide better service to our people after they leave, but then also better understand, how effective our program is, what do we need to do better, and, what are those success rates that promote sustainable recovery? What are the things that we need to do to help them?
So I guess in the end of it here, like what have you found to be the most successful strategy? So the people that you sort of have stayed in touch with, that sort of stuff, the people who have, and I know that the data is not great, but in terms of the strategies that can be put in place to prevent any sort of a relapse, is there anything that you can kind of throw out there as a recommendation?
Absolutely. Our research that we've done over the past number of years have really identified some key protective factors. So similar to identifying some of the 5 primary drivers of addictions, we've identified some key protective factors that really support sustainable recovery. And within the construction and trades, interestingly enough, employer and union support is one of the primary protective factors, right? So the person is leaving residential treatment, they're returning to a work environment. So returning to a work environment that is positive, that supports the person's recovery, similar to, let's just say if somebody had a hip replacement and they're under accommodation returning to work, we would create a work life for that person so that they could recover from their hip replacement.
Yeah.
Okay? A union and an employer relationship that treats addiction and mental health in the same way promotes sustainable recovery. So if we know that Mike Varieur has been in residential treatment, he's coming back to the job site. Let's have a conversation with Mike. Let's understand what he needs to be successful in his recovery. And when that happens, success happens for that person. So we know that's one of the 5 primary drivers, and supporting the person in the sobriety. So if they don't use or drink, they're not using or drinking. So those who remain sober or mostly sober are more likely to achieve their recovery goals. So having a sober workplace, having a sober team to come back to, eliminating triggers within the job site or socially at home, allowing for things to occur within that person's work life that support the recovery. So perhaps they have a 12-step meeting that they have to attend to every day. And a lot of that can be done virtually, or maybe they need to call their sponsor. So creating that space within their work life, for those kinds of things to happen. Maybe the crew that they were working on would tailgate every day after work. Let's not connect that guy back up to the crew that drinks every day after work. So again, a lot of it relates to the work life, the job site, and creating an environment that is conducive to, recovery, sobriety, supporting the person in their aftercare plan, understanding what those goals are, again, from the union and the employer. allowing that person to participate in whatever they need to participate in order to support the recovery, and then really connecting with the family and their significant others. Right. So we know that one of the drivers, again, of addiction is how the job really interferes with relationships and important relationships in the person's life. So allowing time for that person to remain connected with their loved ones, maybe, giving them 15 minutes so they can read a story to their kids over Zoom every night is really meaningful for them. So really thinking outside of the box, not just the traditional, hey, you need to stop drinking or put down the bottle, but, what can we do as a union? What can we do as an employer? How can we help the person with the recovery plan? Let's understand what they need from an accommodation perspective, and then understanding how these drivers are playing out for this person, and then supporting that to eliminate the triggers and the risk factors.
So I'm glad you brought up sort of the support network, because I think that is one of the keys to really, all of these issues is that support network. And I'm sort of wondering if we can kind of take a step back, because one of the things that I sort of wondered a little bit, and I know when we were at the building trades convention, you had handed me and you were showing me sort of the challenge coins that you've got. And you had said, like when there's somebody with an issue, you can issue them this challenge coin and that kind of thing. And I'm sort of wondering, for those of you who are, or for those who are listening here, whether you're a coworker, an employee of the union, that sort of thing, like what should you do? If you feel like one of your coworkers has an addiction problem, like how would you initiate a discussion like that with them to kind of get that ball rolling, to get them the help that they need?
Brian, I'm going to answer that by coming full circle with this conversation, and by suggesting this all starts with workplace education, challenging the stigma of addiction and mental illness within the workplace and within our own community. So once we become more informed and we're educated and we feel more comfortable, we're then able to have a conversation with our people. And I would suggest that the biggest barrier isn't the other person, it's mostly with ourselves. So we might understand that somebody else is really struggling with their addiction. And the question is, how do I have that conversation? I would encourage people to stop and say, what's stopping you from having the conversation? What are you uncomfortable about with having the conversation? And engage in some reflection there, and maybe learning a bit more about, what is addiction? What is mental health or mental illness? What does that mean for me? What does that mean for my community here? So avoiding would be we need to avoid avoiding the conversation. Because if we avoid the conversation, we're also enabling the issue to happen. So I think, unions, employers, everyone on the job site can learn more so that they can be more educated, increase their awareness. We can reduce our misconceptions and our misunderstandings around this disease that we call addiction. We can challenge ourselves, the stigma that we hold, the social stigma in our group, the structural stigmas within our organizations. And then on a personal level, just really being honest with ourselves, genuine and compassionate. This is a person we care about. Let's just have a conversation and let's just ask about it. And we don't need to blame. Just express your concern and ask if they need help. That would be a great starting point.
It's nicely put. It's going back to one of my earlier comments, over the past, decade, roughly, I guess, where we've started talking about it more and that sort of thing. And it has come to the forefront. I think that is starting to kind of open up some of those avenues so people can more comfortably have that discussion. And yeah, I 100% agree with where you're at, where you're saying, like, listen, you gotta kind of look at yourself first, and why aren't you having that discussion with somebody if you genuinely want to see them get the help that they need, right? So I think that's great advice. So I'll open it up to you. Is there any final thoughts that you've got that you'd like to get out to our listeners?
I just like to commend this industry, construction and trade sector. I have a long experience in addictions and mental health, and I've just recently come to the sector over the last couple of years here at Novo, and what is just, genuinely a really great experience is the degree to which you're having this conversation. And, however much we talk about stigma and learning, I think this sector has really jumped into the deep end to address that. And you're confronting your own learning needs and the stigma that is there, and just really engaging and challenging, themselves. The sector has really taken this on. So congratulations. It's wonderful to see the construction and the trades community owning this, identifying people need help, working on minimizing stigma, having healthy conversations about it, and then supporting an organization like the Novo Treatment Center. This is a one-of-a-kind organization. It's entirely funded by the unions and the employers, because they know that people need help. And so this is the only real industry that I'm aware of that has created its own treatment center to help its own people. And as a result of that, de Novo has been able to create treatment and programming and an environment here that is designed specifically for construction and trades workers. So when people come to de Novo, they're living with and recovering with people that have a similar same experience with alcohol and drug use and their backgrounds and so forth. And so actually, that's my feedback to yourself and the community of construction trades. Is amazing work that you're doing to support this. Thank you.
Well, Michael, thank you. I'd like to thank you for coming on the podcast. I'd like to thank you for your genuine words around that kind of thing. I think that this, there's a lot to be proud of in the unionized construction world. And I think this is a bit of the crown jewel really on top of it. It shows the compassion that they have towards their workers. So I brought Michael on today to bring awareness to the issue of addiction, but also to help union members and their contractors understand that there are significant resources available to help workers struggling with addiction and help with how to communicate this difficult message. This is not an easy one. So I'd like to thank Michael, as well as the de Novo Treatment Center, for their time today on OCS Talks. For more information on today's podcast and resources from the Ontario Construction Secretariat, visit our website at iciconstruction.com and follow us on social media.
Ontario Construction Secretariat. Knowledge to build on. Visit iciconstruction.com to learn more.